Thank you also for your earlier comment about how keen you are on negative studies. Having been involved in what I think are still the two largest ever sample size randomised control trials of psychological interventions in young people, both of which were negative. I can see Stephen nodding ruefully there. Then yes, I'm fully signed up to the idea that negative studies can be really important. And yeah, ACAM, it's really nice to be here. I was looking at this sign. I realised that I think I've been a member for well over half of those 60 years. And it's an organisation which I hold in great affection. If you don't belong, you should go out later today and sign up. It is the only multidisciplinary academic organisation for child mental health that I'm aware of, and it brings people together and does fantastic stuff, like today. So join. But Dennis and Joan said, just don't worry too much, just come along, give a bit of an overview, pull it all together, we'll send you the papers so you know what's coming, and it'll be fine. And it's actually, it's a scary audience, there's some fantastic papers, and everybody, because they're bright and sensible and has been thinking about the overview and the challenges, they've already said in one way or another most of the things I'm going to say. Which makes me glad that I put in a little bit of a digression in the middle of my slides at the last minute when I was thinking about this on the train down. Although even that has been touched upon by some of the things Joan just said. So I don't think I've got anything new. But I did want to start, and without an apology for the obvious, with just reminding ourselves of what this is all about. And Joan was touching on this. This is, across the world, the second leading cause of death in 15 to 24-year-olds. It's an absolute tragedy. But this is what is killing our young people. And self-harm is obviously a very, very significant predictor of death by suicide. Rates of both of these things are probably increasing. Until relatively recently, we had little evidence as to what to do. As a number of people have said today, if you go back 10 years, we would have to say, nobody really knows what to do. Which is a horrible thing for a clinician in an emergency department faced with a distraught family with a young person who's trying to take their life. Fortunately, the evidence is now emerging, not just around the kind of, as it were, traditional child mental health intervention once somebody's done it, but also about prediction and prevention. But the evidence is, although it's getting stronger, it's still not great, and it's still difficult sometimes to interpret. And so I wanted to talk a little bit about where we might go next and how we might make sense of what we already know. But first of all, a digression, which is kind of one of the few bits that hasn't been touched on a lot already. This is a paper that I published with colleagues at the Institute of Child Health, and you don't need to read the small print because it's only half the abstract anyway, but it's the title. Joan talked, just an aside, but it sort of, my ears pricked up, about young people in emergency departments, with alcohol and drug problems, and one of the difficulties, which I'll come back to in a minute, about why I think there are so many challenges with self-harm research, is that self-harm is not a diagnosis, it's a behaviour. And it covers a wide range of behaviours, many of which we can't agree about how we define. But it has a lot of overlaps with other risky behaviours that young people do, like taking drugs and alcohol and driving fast cars. Often, and Joan's picture showed all three of them happening together with her teenagers. The driver in the car had a bottle of something that he was drinking from, and I suspect it wasn't lemonade. So what did we do in this study? We took, using routinely collected data, which is also something I want to return to, but we took every 10 to 19-year-old admitted to an emergency department in England over a 5-year period with an injury. That was over 1 million people, 1 million 10 to 19-year-olds. And then we looked at NHS Digital, which is for Joan, that you may not have come up, but that's where all NHS data goes to die. And hospitals and clinicians put data into computers, and trusts analyse it and summarise it, and then it gets forwarded onto a central database. And with the right permissions, you can access it for research. So we downloaded information on all 1 million young people aged 10 to 19 who'd been admitted to A&E, to emergency department, with an injury. And we divided them into those where the injury was clearly accidental and those where the injury was related to self-harm or drug or alcohol abuse or violence. So some self-harm, but not all. But there is, I think, this overlap. Logically, of course, we'd call it accidental injury and non-accidental injury, but non-accidental injury has another meaning to all of us, so we couldn't call it that. So we called it adversity-related injury. It's a kind of subset. I suspect these people have lots of ACEs, but we're not talking about ACEs here, and we're not talking about non-accidental injury, but it's an injury where the drug or alcohol or violence or self-harm has resulted in the injury. And then we look to see who died in the 10 years after. First of all, the raw data, as it were, there were about a third had adversity-related injuries and 2/3 had accident-related injuries. And overall, nearly 5,000 died in the subsequent 10 years, about 0.5% of the overall number. If you'd had an adversity-related injury, you were 4 times more likely to die in the next 10 years than if you'd had an accident-related injury. You'd fallen off a swing or something like that. And the deaths were related to suicide, obviously some of them, but also to drug and alcohol use and violence. A few people were killed in violence, but a number died through major association with drug or alcohol misuse. And the death rates were the same whatever the initial type of adversity that led to the initial injury. So what does that mean? Again, you said a couple of times you don't know what happens in the UK. I don't know what happens in the US. But in the UK, we have national guidelines about what to do with self-harm. We spend an awful lot of time worrying about the best way to provide that seatbelt for youngsters who've self-harmed and come into emergency departments because we know they're at risk of dying. The young kids who come in because they've had too much to drink and they're found in a gutter or they've got in a fight or things like that tends to be stigmatised even more by emergency department staff than do those who've self-harmed, and they're often patched up and sent out with any kind of follow-up. And yet what this data shows, and I think it's pretty solid and reliable because of the large numbers and the way it's collected, is that actually those young people who come in with alcohol and drug-related injuries are just as likely to die as the ones who come in with self-harm, and yet we ignore them. And they're quite likely to die by self-harm. This doesn't breed true. The ones who come in with an alcohol-related injury don't die of an alcohol-related injury. They often end up... So I think this is, it's one of those Venn diagrams where there's a lot of overlap. So I headlined this little bit a digression, but one of the things I think we need to be thinking about is who are the population we're dealing with and what are the overlaps with other populations. And maybe it's different in Norway or America, but certainly in the UK, we deal with these two groups that actually have a lot in common and who often die by similar means in very, very different ways. And the implications for how we might behave in A&E and how we might fund the increased services we would need to provide in emergency departments to deal with all of these young people rather than just some of them are immense and I think largely being ignored. So back to the subset that are self-harm. Why has it been so hard to obtain evidence about what to do with self-harm? And it's not just a problem, I think, for self-harm studies. I'm a proud owner of 2 negative studies, and there have been quite a lot of them about. And it's often the big, pragmatic phase 3 randomised controlled trials that we struggle to get answers from. And I'm not entirely sure why that is. I think sometimes it's about the interventions. That do we really believe that a kind of one-size-fits-all intervention is going to work for such a large group of participants? Sometimes it's about the participants themselves. They're very heterogeneous. And again, I think with self-harm, it's not a diagnosis, it's a behaviour. Everybody's self-harm is different, but actually there are, I think, probably many, many different reasons that drive self-harm and many different types of self-harm and many different types of people that self-harm. And we often we're so desperate to recruit the number of people that it says the statisticians say we was getting our sample size, that they're a rather heterogeneous group that we end up with. Then there are the comparisons we use in our big pragmatic trials. In the UK, treatment as usual is rather good. And actually, in our study, the SHIFT trial, then there was quite a flexible, structured family therapy delivered by quite skilled practitioners. But in treatment as usual, very skilled practitioners were allowed to see the children for an assessment and then decide what treatment as usual was best for them. So they got a range of different things that were geared towards, that we didn't specify a single treatment as usual, because ethically, the feedback we got from patients and from ethics committees was it would be very difficult to do that. And it was a pragmatic trial, so we were comparing it against what's normally done. So in our treatment as usual group, they got what an experienced clinician had decided was what was best for them given their circumstances and situation. In the experimental group, they got family therapy. That doesn't feel like a good recipe for getting the kind of answer you want. And then you've got the designs themselves, and I'll come back to that. So let's think about some of the specific challenges with self-harm. And I'll say straight away that I don't have any answers, just problems. But the first one is language and definition. We can't even agree on what we mean by self-harm. And again, others have alluded to this. Self-harm in Europe and Australasia often means all attempts to hurt yourself deliberately, irrespective of intention to die. In the US, predominantly, although Joan was talking about how she started to use these terms differently, but there are divisions into suicide attempts with intention and NSSI. The very name implies that there's no suicidal intent. And yet when we look at the longitudinal population studies, they show that people that you categorize, there is at least a clear definition of NSSI and you can allocate people to it. When you look at the population studies, those kids go on to die by suicide. So do we really think that they had no suicidal intent when they first cut themselves and then suddenly developed it? Or could it be that some of them were? As a clinician, I talk to people in the emergency department and they can't tell me whether they had suicidal intent or not. Part of the reason this is so difficult is because it's hard for us to judge, and sometimes it's hard for the people who've done it to judge and for their families. So in our trial, we had over 800 people, so it's quite a large group. And what we found was when we looked at the people who repeated, there was a lot of mixed methods, as it were. A lot of the ones who started off with cutting went on to overdose or use other means. A lot of the ones who started off with an overdose went on to do cutting. Other longitudinal studies have shown the same thing. So is it a helpful distinction? I'm not sure that it is, but I'm also sure that we probably ought to be cutting up this large group of young people, cutting is the wrong word, dividing up into more meaningful groups. I'm just not sure that I know what the more meaningful groups are. But I think that some of the work people like Abigail are talking about, might be one of the ways we need to go when it comes to that division. Then we've got measurement. How do we measure self-harm? A lot of the studies are self-report. I remember talking to Jonathan Green, who did the ASSIST study in Manchester. They went and asked people, how many times have you self-harmed recently? Some of them were cutting 20, 30, 40 times a day. When you go back 3-4 months later, how can you possibly accurately measure that and what do we want to measure? Again, Joan flagged this up. What is our primary outcome? Is it in our study? It was time to first repetition that led to admission. So quite a hard and high level marker. In other studies, it's whether they've self-harmed at all in the period. In other studies, it's the amount of self-harm in one group compared to another group. These are all very different ways of measuring self-harm, even if we can agree about how we define self-harm. And there's no consensus. And it's a nightmare when you're reviewing the literature because everybody uses different terminology and everybody uses different outcomes. And it's not even clear when you read it what their definitions are or what their outcomes are. So I end, how Dennis does it. And I'm with Dennis starting to work on a large systematic review and meta-analysis. And it's a real struggle. And how long do we go on? Yes, it's great to know that people improve quickly. And I think that notion that a fast improvement, if it was my teenager, I'd feel that if they got better quicker, that's good enough for me. I don't care if the other group catch up later. But is it important that treatment effects don't last? And how long should follow-ups be? The longer you have the follow-up, and our funders in the UK often like long follow-ups, the harder it is to get a continuing statistically significant. So we sometimes shoot ourselves in the foot by insisting on those. So the way to go, I think, is going to be solving some of these. We need to get together and agree on definitions, agree on things to do. But I think some of the way is probably what you might think of as precision medicine or personalised medicine. We need to start thinking about what's going to work for which child, not what's going to work for every child. I love the I've read all the papers in the practitioner review, I had advanced copies. There's some fantastic stuff there. And I love the pathway approach that Dennis and Joan have taken, so the way they've laid it out, and I think Lars in the editorial, about prediction, prevention, treatment. There's a logical pathway there, and I think we need to start thinking logically about, how one thing leads to another leads to another. I think we need to make smarter use of what we know about predictors and moderators and the biogenetics in order to start dividing up into meaningful groups. I think we need to use logic models to define our interventions. It was great to see Lars's chart about the kind of theoretical notions about what might be going on and how you can empirically test that and then look for mediators. And I think we need to be thinking for the different sorts of meaningful self-harm that we get, what are the right interventions and what's the evidence base from what we know about predictors and moderators and mediators to develop an appropriate intervention for that group of self-harm. And I think we can learn from cancer trialists and people like that who are using innovative research designs. Adaptive designs with planned opportunities to stop early, differential accruals for different arms, depending on how you're going at an intermediate analysis, umbrella protocols that allow us to assign different treatment strategies according to risk markers and biomarkers, and Zealand-type post-consent randomization protocols that take account of people's personal wishes. All of these, I think, are becoming standard practice in other parts of medicine and health, but we've not yet caught up with. And going back to my digression about the big national data set, we could make better use of routine data. That we all work in health economies where a lot of routine data is connected, and trials within routine data, trials that retrospectively randomise according to the routinely collected data that we've got, and then follow through, represent astonishing opportunities for us. None of this is easy. It requires us to talk to each other and to collaborate more, and to share our data and what we do. Some of you know I'm trying to get you to share data with me at the moment, so I can't resist saying that. But my final word would just be about implementation. I went to a talk at the King's Fund some years ago where a health economist told me that if we stopped doing research today, it would take another 20 years just to implement all the stuff we already know works. And when I was a junior doctor, when I first joined ACAM, people were publishing research about the effects of expressed emotion on schizophrenia treatment and relapse. And it's grade 1 evidence. We have lots of studies from different groups showing very, very clearly that if you utilise psychological interventions to reduce expressed emotion, you can radically reduce schizophrenia relapse in adults. Again, I don't know what it's like in Norway or America, but in the UK, 30 years later, people don't routinely use psychological, family-based educational treatments to reduce relapse in schizophrenia, despite the fact that it's almost certain that it works. Not for everyone, but for many. Why not? Because bring out a new antipsychotic, there's a lot of marketing, and all you've got to do is learn to spell it. A psychological treatment requires major changes to the whole health delivery system, training for staff, resources to train staff, new ways of working. So it's great that we're starting to get evidence, but I'm afraid if I had to bet my pension, I'd say that for most of us, it won't get implemented for a long, long time, even though we know it works. And that's another big challenge we all have. Thank you.